Thank you, Shaji sir. Thank you so much for your encouraging comments. And also, in this time, I thank all the organizers of this program for giving me an opportunity for presenting a topic in this session. So, thank you so much. And Seth sir is also attending this session. Thank you so much, sir. And this time, so I thank all my teachers who taught the lessons of homeopathy as well as practice of medicine. And also, I humbly remembering all my teachers in this situation. So thank you so much, sir. So coming about the topic, today's presentation. So my topic is post-COVID cardiopulmonary symptoms and scope of homeopathy. So as we all know, so we are in COVID as well as post-COVID season. So we can call it as either COVID or post-COVID season, because we are having still we are having COVID cases, and also we are having post-COVID complications also. So I think COVID as well as post-COVID season. So still we have, so we are in the second spike of this COVID. So still we have more cases as well as complications are there. And since it is a new infection, so many of us, we don't have a very good idea on what are the complications of post-COVID syndrome. So we have to learn more about that. So that's why I'm presenting this topic. And also we see many post-COVID cases in our OP, post-COVID cases presenting with the respiratory symptoms. So we need to study, we need to learn more about that, the post-COVID symptoms. So here, so what I am sharing to you is the data I have collected from different sources. So that's what I'm sharing to you. And but I'm not going to discuss all of the post-COVID complications, all of the post-COVID symptoms in today's presentation, because I'm not an expert in telling you everything about this post-COVID symptoms. So I will be focusing on one symptom, and it is post-COVID, and more specifically speaking, it is exertional dyspnea, post-COVID exertional dyspnea, and can be a symptom of both the cardiac as well as this pulmonary symptom. It can be either a cardiac symptom or a pulmonary symptom, or it can be a symptom of other general systemic diseases, including anemia. So I'll be I'll be focusing more on this symptom, this post-COVID dyspnea. So we have to study, we have to learn more about this post-COVID dyspnea. So its clinical presentation, how to identify a post-COVID dyspnea, or how to differentiate it from other non-COVID causes. That's what I am focusing in today's discussion. So can I have my slide share, sir?
Yeah, please. Please proceed.
Okay, so as I said earlier, my topic is post-COVID cardiorespiratory symptoms and scope of homeopathy. So why cardiopulmonary symptoms or why cardiorespiratory symptoms means? So as you all know, so we are having more patients with the dyspnea on exertion. That's a very common symptom that we see in our OPD cases. So it can be either a post-COVID symptom or a non-COVID symptom. There are so many non-COVID causes are there. And also it can be a cardiac symptom as well as a pulmonary symptom. So in COVID-19, so we know, so many patients are presenting with the symptoms like dyspnea on exertion, or sometimes maybe palpitation, and some patients are having chest pain. But this exertional dyspnea, or simply as dyspnea, can be a symptom of cardiac symptom, So due to persistence of inflammation in the cardiovascular system, or it can be a pulmonary symptom due to persistence of inflammation in the lung parenchyma. So it can be both cardiopulmonary symptom and it can be a symptom of other systemic illness. For example, if we see, so if we analyze 10 cases of patients present with the dyspnea on exertion, so maybe you may be having 10 patients in your OPD with the dyspnea on exertion. So when you analyze that case, so one or two, in this current situation, one or two patients may be a post-COVID presentation, and about 2 to 3% cases may be having this significant cardiac or significant pathology, and the remaining cases may not be having any significant pathology. So this can be a simple symptom without any significant pathology. So we have to identify which patients are presenting with this significant cardiac or pulmonary involvement due to due to post-COVID persistent inflammation. So that has to be identified. So in today's discussion, we will be discussing on how to identify a post-COVID dyspnea and how to or how to distinguish it from other causes of patients presenting with the dyspnea on exertion. So so you have to learn more about those things. So because since it is a new infection, so we don't have much idea on what is happening in the post-COVID period. So or what are the symptoms or the cause of those symptoms. So all those things have to be studied. So today's presentation will be focusing on so how to identify a case of post-COVID dyspnea and how to differentiate other non-COVID causes of dyspnea, because this is a very common symptom. Many of the patients are presenting in our OPD with this particular symptom, dyspnea on exertion, and that's why I'm focusing on this particular symptom. But I'm not going to discuss all the symptoms, all the post-COVID symptoms, because I don't know much about others. But since we have to learn more about these things, this causes of dyspnea, exertional dyspnea, and how to identify this post-COVID dyspnea from other conditions. So we have to learn much about it. That's why I'm focusing this symptom, this dyspnea on exertion. Okay, there are increasing reports of persistent prolonged effects after COVID-19. We see that many patients are presenting with many symptoms after having a COVID-19 infection. And also this dyspnea, so along with, as you all know, this chronic fatigue is a very common symptom after this COVID-19 infection. So along with this chronic fatigue syndrome, we have this dyspnea also. So these two are the very common symptoms many of the patients are having during post-COVID season. So studies have shown that about 42 to 66% prevalence at 60 to 100 day study follow-up. It has shown that about 42 to 66% prevalence in the post-COVID dyspnea. So many studies are going on because it's a very new infection. So you have to study more about those things. Then, so let us see what is long COVID or post-acute COVID. So you might have heard about long COVID, then chronic COVID. So long haulers. So these are terms familiar to you. So maybe knowing all these things, I'm not going to explain everything about these things. May be boring to you because I know you all will be familiar with these things. So anyway, what is long COVID means, as all of you know, this COVID, the infection lasting for up to about 3 or 4 weeks. So when your patient get a positive PCR result, he may or may not have symptoms. As you know, about 80% of the patients are not having symptoms, and about 20% patients only have symptoms. In that 5% are going for severe illness, and among that 5%, only less than 5% patients are going to have a ventilatory support, require ventilatory support. So that's the picture that we see, and all of you might be knowing all these things. Anyway, what is long haulers or what is long COVID? That means, so usually when a patient get a positive result, he'll be okay by about 3rd or 4th week. Maybe having symptoms, may or may not be having symptoms. So he will be okay by about 3rd or 4th week. So when the symptoms persisting for more than 4 weeks, we can call that condition as long COVID, or otherwise known as post-acute COVID-19. So that's long COVID or post-acute COVID-19, and patients themselves describe it as long haulers because they'll be carrying along with those symptoms. So that's why they describe themselves as long haulers, and otherwise it's known as long COVID. So when symptom persisting for more than 4 weeks, it is long COVID or post-acute COVID-19. And next comes chronic COVID or post-COVID-19 syndrome. So here, some patients may be getting symptoms lasting for more than 3 months or more than 12 weeks. And that's known as chronic COVID. So we have long COVID as well as chronic COVID. So the two things. Then why are some people affected? So not everybody is getting these persistent symptoms or discomfort after having a COVID infection. So why some people are affected, but it's not still not known about what's the reason for having these persistent symptoms. And there are some factors that may contribute for the development of symptoms. That is, so it's due to persistent viremia, and that persistent viremia can occur either due to weak or absent antibody response. For example, so we do not have any idea on how long the antibody persists. So still we don't know how long antibody persists. So weak or absent antibody response may be a reason for having persistent symptoms. That is one thing. And sometimes relapse or reinfection may occur as we don't know about how long the antibody persists. So when there is no antibody after having an infection, there will be relapse or reinfection. That's one reason for having persistent inflammation. Then inflammatory and other immune reactions. So as you all know, inflammation and immune reactions are common in every infection because we have immunity, we have some protective mechanism in our body. So inflammatory as well as immune reactions are common after every infection. So here also, there will be some inflammation as well as immune reaction. But the peculiarity of this COVID infection is we all know there will be hyperinflammation, there will be immune dysregulation. So all these things, all these terms may be familiar to all of you. Hyperinflammation and immune dysregulation. So hyperinflammation will be there. That may be the reason for persistent inflammation. That's one thing that can contribute to the persistence of symptoms. And next comes the deconditioning of the body. So as you all know, deconditioning. So after having a debilitating illness, we get some changes in our organ system. So deconditioning may occur after having a debilitating illness. That may be the reason for having persistent inflammation. COVID-19 that happens in many other infections also. So here also, since it is an acute infection and sometimes a debilitating infection, deconditioning in the body may occur. So that may be one reason for having persistent inflammation. Then mental factors such as post-traumatic stress disorder. So that may occur because, so mental factors, that means as you all know, COVID-19 infection. So in the initial days, now also, so it needs some isolation. So social interaction may not be there in patients. In some patients, that may cause some mental depression and may lead to this post-traumatic disorder. So all these things may contribute, or some one or two factors may contribute for the persistence of inflammation, and the exact cause we don't know. So these things are said to be the reason for persistent inflammation again. So here you can see a picture showing the picture during COVID as well as post-COVID scenario. So here you can see so initially after having 2 weeks of incubation period, so here you can see after having 7 or 8 days, we will be getting a period of viremia, and then you will get a RT-PCR positive test. And after 2 weeks or 3 weeks or by the end of 4th week, if everything go normal, the patient will be okay by the end of 3rd or 4th week. But some patients, a minority of patients, will be getting some persistent symptoms, and that is the subacute or ongoing COVID, or the post-acute COVID, or the long COVID. As I said earlier, symptoms persisting more than 4 weeks, and they are long haulers or post-acute COVID-19 or long COVID patients. But symptom persisting for more than 12 weeks, or when it is persisting for more than 3 months, it's known as chronic COVID syndrome. So when we analyze the symptoms of this post-COVID period, we see that many of the patients are having fatigue as well as dyspnea. So these are the common symptoms after having a COVID-19 infection. So fatigue with the decline in the quality of life, as you all know. So when a patient is having fatigue, there will be a reduction, a decline in the quality of life. Means he may not be active, or the patient may not be active as earlier. So there will be a reduction in the or decline in the quality of life when a patient is having fatigue. And fatigue is common after every viral infection, and this is also a viral infection. And in some patients, this will be a debilitating illness. So and can cause fatigue in many of the patients. I mean, many of the patients. And when a patient having fatigue, so he may be having dyspnea on exertion, because a patient with fatigue may not be so active. Will be dull in many of the situations. The patient will be dull. So that can also be a presenting symptom. That can also present as dyspnea on exertion. So the next common symptom is dyspnea, and majority of the patients are presenting with the dyspnea on exertion, or simply as dyspnea. And cough is not a common constant symptom of post-COVID patients, but some patients may be having cough, and many of the patients will be requiring persistent oxygen support. So these are some of the things that we see in post-COVID patients. And some patients may complaining of anxiety or depression. As I said earlier, post-traumatic stress disorder, that is one common presentation in post-COVID patients. And majority of the patients may be complaining of sleep disturbances. That's also one thing that we usually see in patients. And some patients have cognitive disturbances or brain fog, and some patients may be complaining of headaches. Then palpitation and chest pain are two common presentation of this post-COVID patients. And some patients may be having thromboembolism. So this thromboembolism may usually present as, some patients may present as stroke, and some patients may have pulmonary infarction, and some patients may have sudden heart attack. And you might have heard some patients have sudden cardiac death. So that's also one presentation, and that's due to this thromboembolic events occurring in patients. So we'll come to that slide. So what is thromboembolism? What's the reason for having thromboembolism? So we'll come to that slide. So many of the patients are present with the thromboembolic events. That's also one presentation. Then chronic kidney disease, many of the patients are complaining chronic kidney disease after having a chronic this COVID infection. Then some patients have hair loss, a very simple symptom. We know many of the patients after having a debilitating acute illness, they will be having hair loss. It's not a serious problem to be considered. But there are serious problems to be considered after having COVID-19. So one thing is dyspnea and dyspnea on exertion. And second one is this cardiac complaints presenting with palpitation as well as chest pain. So these two things, so we need to be considered seriously. So others are, some of the symptoms are common after many of the acute infection, acute both viral as well as bacterial infection. So, so it's about COVID and post-COVID period. And here this picture showing some study reports. So these are study reports from different parts of world. So this study has been conducted in hospitalized patients after getting a discharge from the hospital. That's why the percentage will be slightly higher compared to common population. So these are studies from different parts of world, one in Italy, UK, France, and China places. So let's come to the pathophysiology of this COVID patient or post-COVID patient. So these can occur during COVID period, and as well as persistent inflammation may occur in post-COVID period also. And that's why patients presenting with this persistent symptoms during post-COVID period. So these things, these pathophysiological changes, patients can have these symptoms during their acute infection also. But in some cases, this may persist for some duration. So let us see what is happening in, what is the pathophysiology behind this COVID-19 infection. So as you all know, the virus gain entry into the cells through the ACE2 receptor. So we have ACE expression in different parts of our body, and even from the nasal mucosa, we have this ACE expression. So different parts of the body, there is ACE expression. That's why this COVID infection or this virus affecting different parts of the body, causing inflammation, different parts of the body. So we have ACE expression in our respiratory tract, in our cardiovascular system, and even in our gut. And that's why patients presenting with the loose motion when they are having this COVID-19 infection. So ACE expression is there in different parts of the body. So here, so the virus gain entry into the pneumocyte. So here it is respiratory tract, and we are discussing about post-COVID dyspnea. That's why I'm telling all these things. So after gain entry into the pneumocytes, so we know this virus affected the pneumocytes and directly entering into the alveoli, causing some damage. So alveolar damage will be there, causing hyperinflammation. As you know, in every infection, we will have some inflammatory response, some immune regulation. So these things are common in every infection. But here in this case, so the virus damaging the alveolar epithelium, that is one thing, and causing hyperinflammation. And one more thing is there will be endothelial damage. So the alveoli will be damaged, the alveolar epithelium will be damaged, and then the endothelium also will be damaged in this case. So these two things, so when we consider our respiratory tract, our alveolar epithelium, then and the endothelium of pulmonary capillaries, so we know that that's the area where diffusion takes place. So proper diffusion, we should have proper ventilation and proper perfusion. So both these things should be there for the proper functioning or the normal functioning of our respiration. So, but these two areas are damaged in our COVID-19 infection. So our alveoli will be damaged because of inflammation, and endothelium is also damaged. So two things are there for the endothelial damage. One is, so this virus is directly attaching the alveolar ACE2 receptors. So ACE2 expression should be there in our body for the normal functioning of our vascular system, for the endothelium. So when there is less ACE2 expression, so here the ACE. Okay, so this is pulse oximetry to identify whether the patient is having hypoxia or not. So many of the patients may not be having dyspnea at rest because in this COVID-19 infection, as all of you know, patients may be having happy hypoxia because they may not be having symptoms of hypoxia. So, so to identify whether the patient is having hypoxia, you can use this instrument. It is a very simple instrument which can be used even in our OP setup. And moreover, many of the patients, even ordinary people, may know about this pulse oximeter. And prior to COVID-19, this was only a medical device, and medical people may be knowing about this thing. But nowadays, ordinary people also know about this pulse oximetry and pulse oximeter, everything. Okay. So that is pulse oximetry, and here it is a spirometry, one investigation. So to identify whether the patient is having restrictive pathology or an obstructive pathology. As all of you know, here in this COVID-19 infection, so the area of pathology we know, the lung parenchyma is involved in the disease process. So naturally, it's a restrictive lung pathology. So instead of having that obstructive lesion as we have in other COPDs as well as bronchial asthma, there we are having this obstructive lesion, but here in this case, it is a restrictive lung pathology. So to identify that patient is having restrictive pulmonary lesion, so we can have this investigation, this spirometry. So it's also very simple investigation. Nowadays, many of the hospitals are having this instrument, this spirometer or spirometry, the procedure. So these two things are to identify the respiratory involvement, especially in COVID patients, especially when we suspect COVID-19 persistent inflammation in patients. Okay, so the previous slides were showing the pathophysiological mechanism and the area where this pathology or this infection affected. So here, so patients may be having those symptoms or parenchymal damage or alveolar pathology. Those things are there. But when you have a patient in front of you, the presenting symptom of the patient will be dyspnea. So simply breathlessness. That is a symptom of many of the patients. And second one, patient will be telling you, doctor, I am having difficulty in breathing, and and I am not able to walk with others, and not able to walk with a person of my age, and I am not able to climb upstairs, or I am feeling some suffocation in my chest. And I'm not able to talk rapidly. So those are the common symptoms many of the patients will be telling to you. So dyspnea and decreased exercise capacity, and these two together constitute Our symptom, dyspnea on exertion. That's our topic of discussion, today's discussion. So dyspnea and decreased exercise capacity. So to know that or to identify that patient is having hypoxia, you have to use that device, pulse oximeter. So many of the patients, if it is post-COVID, may be having, or when they are having this type of pathology, they will be having hypoxia. And you can identify hypoxia by using that simple device, pulse oximeter. Okay. So when there is persistent inflammation lasting for long duration, patient will be having this type of pulmonary pathology. You may be knowing that constant inflammation or when you have chronic inflammation in the body, it will be usually naturally healing with some fibrotic changes. So as also in the lung parenchyma, so when there is persistent inflammation, healing occurs naturally by the fibrotic changes. So you will be getting a fibrotic lung, but we don't have a clear idea about whether fibrosis is taking place in the lung parenchyma or not, because there's new infection. So still we have many things to study about this infection. So this is what can occur during COVID infection. So this is a possibility. Fibrotic damage or fibrotic tissue may occur in the lung parenchyma. So now coming to the cardiovascular pathology. So in the previous slides, we were discussing about the pulmonary parenchymal pathology or respiratory pathology, and now we are having a cardiovascular symptoms or cardiovascular pathology. So two things are there. So direct viral invasion as well as thromboembolic events. So virus directly may enter into the cardiovascular tissue or the heart muscle and can cause myocarditis. So similar to inflammation in the lung parenchyma, here the virus can directly enter into the myocardium and can cause myocarditis. That's why many patients are having myocarditis after COVID-19 infection, after COVID infection or during post-COVID period. So as in the pulmonary parenchyma, here also there is a tendency for having fibrotic damage. So as usual, myocarditis, inflammation. So chronic inflammation may lead to fibrotic damage. So fibrosis can occur in the cardiac tissue also or cardiac muscle also. So and the next thing is thromboembolic events. As I said earlier, there will be microvascular injury, endothelial damage or microvascular injury leading to thromboembolic events. So that thromboembolic events. So usually in the cardiovascular system, so it's usually affecting the coronary arteries. So as you all know, so when a coronary artery get blocked, what happens in the future, you know. So myocardial infarction or heart attack is a possibility. Then microinfarcts can occur when there is blockage of small vessels or medium-sized vessels. Microinfarct can occur. So myocarditis can occur. Then in some patients may get myocardial infarction or microinfarct. So finally, the patient will be having cardiomyopathy and commonly ischemic cardiomyopathy. So when there is cardiomyopathy, so we know cardiomyopathy means dilatation or enlargement of the heart. So when there is an enlargement of the cardiac tissue, cardiac muscle, so we all know that there is coronary circulation. So when the muscle gets hypertrophied, there will be an imbalance between demand and supply. So that in turn can cause myocardial infarction or again a heart attack. Possibility of heart attack will be more in patients with the cardiomyopathy. Then in patients with the COVID infection or during post-COVID period, some patients may be complaining of palpitation, and such patients will be having this premature ventricular complexes, and usually written as VPCs, ventricular premature complexes. And many of the patients are having ventricular tachycardia, and some patients may be present with atrial fibrillation. And finally, patient will be getting cardiac failure. So when a patient with cardiomyopathy, so as I said earlier, a demand and supply imbalance may be there. Heart attacks can occur or massive heart attacks can occur in such patients. And when the myocardium is grossly damaged, there will be a possibility of cardiac failure in such patients. So these things are happening cardiac muscle or cardiovascular system in patients with COVID-19 or during post-COVID period. So when you get confused on seeing all these things, simply telling this virus can damage the myocardium directly, causing myocarditis, and it can cause some changes in the blood vessel, causing blockage of blood vessels. Simply, we call that condition as coronary artery disease. And because of these two things, many of the patients are getting symptoms either due to cardiomyopathy or many patients are getting tachycardia or atrial fibrillation. And we see that many patients after getting COVID infection will be coming to the OP with tachycardia. That's a very common symptom that we see after COVID-19 infection. So that's the pathophysiological mechanism in cardiovascular system. And again, so when a patient is having this type of pathophysiology in the or pathological mechanism in the cardiovascular system after having a COVID infection, so he might be presenting with these type of symptoms, either a shortness of breath. That's one presenting symptom. As I said earlier, in the pulmonary parenchymal damage, there also patient will be having breathlessness or shortness of breath. Here also patient will be complaining of dyspnea on exertion. And in pulmonary disease and in pulmonary parenchymal damage also, patient will be having either dyspnea or some patient may be telling you, I'm having dyspnea on exertion. Okay, and next symptom will be palpitation. So because of that tachycardia or arrhythmia, patient will be presenting with palpitation. Patient will be telling you, I'm having an unpleasant awareness of my heartbeat. That's a symptom usually patients are telling. So palpitation and unpleasant awareness of heartbeat. And next symptom can be chest pain or discomfort in the chest. So might be due to this thromboembolic events. Maybe some coronary arteries may get blocked and can cause chest pain, or else this cardiomyopathy can cause an imbalance in the demand and supply, and that can also present with chest pain. Okay, so these are the presenting symptoms when a patient is having some pathological mechanism affecting the cardiovascular system after having that COVID-19 infection. Okay. So am I going too fast? Or can continue in this pace?
Yeah, continue. Continue, doctor.
Okay, okay, thank you. So now we come to the that symptom, that particular symptom, dyspnea on exertion. As you all know, that is many of them is not a post-COVID symptom. So when you analyze, as I said earlier, when you analyze the patients in your OPD in these days, in this COVID situation, maybe one or two having this post-COVID pathology, and many of them having may not be having significant pathology, significant illnesses. So you have to identify that post-COVID symptom, and you have to differentiate that post-COVID patient from other symptoms, other symptoms presenting, other disease conditions presenting with this dyspnea on exertion. So let us see what are the non-COVID causes of dyspnea on exertion. So first one, so this first one I've written here is this recent weight gain. So you might have seen in many patients when they get recent weight gain, the initial symptom they noticed would be a dyspnea on exertion, because recent weight gain. So when they a recent increase in the weight gain, so that is it's a very common thing that we see in our OPD cases, because as we all know, so NCDs are increasing. So NCDs means non-communicable diseases. So I'm expanding all these things because, as I was told earlier, so many non-homeopathic patients, non-homeopathic people are also attending this session. That's why I'm expanding all these things. So NCDs, non-communicable diseases, it's very common nowadays, and many of them are having morbid obesity. So this weight gain may be a reason for this presenting complaint, dyspnea on exertion. So that is one thing have to be considered in many cases. Okay, and this weight gain may be due to lack of physical activity. So as we all know, so we were having a period of having a lockdown period. So maybe lack of physical activity might be there. So that is one reason for having weight gain. And secondly, hypothyroid is very common these days, because as we all know, autoimmune hypothyroid diseases are on the increase. So many autoimmune diseases are autoimmune diseases are more in these days. So as also hypothyroid, it's also one autoimmune disease condition. May not be having goiter as earlier. So earlier we were having this goiter as a presenting symptom of thyroid dysfunction, but nowadays, so instead of having that neck swelling or goiter, patient will be having hypothyroid with a high rates of TSH. And they may be having morbid obesity, and some are having hypertension, and some may be having dyslipidemia like that. So hypothyroid patient or hypothyroidism should be differentiated when you have a patient with these presenting with this type of dyspnea on exertion. So that is one thing to be considered. And then some of the musculoskeletal problems, musculoskeletal diseases. For example, we know, so when a patient is having, for example, costochondritis, that's a musculoskeletal problem, or when having myalgia affecting chest. So when he takes his breath in, he will be feeling that suffocation. So that can also present with this particular symptom, dyspnea on exertion. And one more thing, some patients with this type of ankylosing spondylitis. So it's one disease condition affecting majority of many male patients after having 30 or 35, 40 plus. So they will be having ankylosing spondylitis, and ankylosing spondylitis, as you know, the presenting symptom will be stiffness. So when the vertebrae are involved in the disease process having stiffness, they will get the suffocation when they take their breath in. So that is one condition presenting with the dyspnea on exertion. So those things are to be considered in the differential diagnosis. Those simple things are to be considered in the differential diagnosis when you have a patient with the dyspnea on exertion. So starting from the simple things to complicated. So that should be the way of differentiating conditions. And then comes the fluid retention. So fluid retention from any cause, maybe a malnutrition that can cause hypoproteinemia, and that can cause fluid retention. And even simple cases like some lady patients, when they are in the premenstrual period, they will be having fluid retention. So and in some ladies this will be more the fluid retention with this type of symptoms. So those things are simple things that also have to be considered in the differential diagnosis. And next comes anemia like illnesses. Some systemic diseases can also present with the this dyspnea on exertion. That one is anemia, where we know these anemic patients are having hyperdynamic circulation, and that may be one reason for having dyspnea on exertion. As well as pregnant ladies, they're also having this dyspnea on exertion. And thyrotoxicosis is another condition having this hyperdynamic circulation. So these conditions are also presenting with the dyspnea on exertion. So those things are to be considered in the differential diagnosis when you have a patient with a dyspnea on exertion in your OPD. Okay, and next comes the pulmonary diseases. So when talking about pulmonary diseases, so now we have seen what are the changes in post-COVID dyspnea or post-COVID patients, and the clinical presentation, the way of symptomatic presentation that we have seen in the previous slides. And now we have non-COVID causes of this dyspnea on exertion. So here in the non-COVID cause of dyspnea on exertion, here we have so it's very easy to differentiate other conditions presenting with the cough and expectoration, because we know a patient with the respiratory symptoms, when that patient is having a cough and much expectoration, so that would be a disease condition affecting the airway. So airway disease is having more cough and expectoration, whereas interstitial lung diseases means the diseases affecting the lung parenchyma. So such conditions are not having much cough. Cough may be there, but much expectoration is not a phenomenon that we see in restrictive lung diseases. But we know this post-COVID is a restrictive lung disease, a restrictive pathology is there. So diseases affecting the lung parenchyma have to be differentiated from post-COVID dyspnea. So we can rule out airway diseases. So when that patient is having cough and expectoration, it's usually having some airway disease. So along with cough and expectoration, you'll be having some dyspnea. Okay, so that's there. So that has to be ruled out, this airway diseases. And next comes the this restrictive lung diseases. In that we have all ILDs, interstitial lung diseases, and we have this occupational lung diseases. So all are affecting the interstitium, where we will get this dyspnea on exertion. So those conditions have to be considered in the differential diagnosis. Okay, so and when you take the history, we'll get some points regarding the diagnosis. So from that we can make out a differential diagnosis of those conditions. And one airway disease which is having this dyspnea on exertion is emphysema, that you may be knowing emphysema. What is emphysema? And that's also affecting the lung parenchyma, the alveoli. So the alveoli gets damaged in this emphysema, and there you will be getting this dyspnea on exertion. So those things have to be considered, as well as some airway diseases. For example, if it is a bronchiectasis, when there is extensive lesion and when there is progressive damage of progressive involvement of lung parenchyma or progressive pathological changes in bronchiectasis, that can cause this dyspnea on exertion, or that can cause dyspnea. Otherwise, cough and expectoration will be the common symptom of patients with the bronchiectasis. So those things have to be differentiated. And then pulmonary hypertension, one condition presenting with a dyspnea on exertion. So those things have to be considered in the differential diagnosis. And finally, we have diseases of pleura, and a patient with pleurisy, when there is inflammation of layers of pleura, you will be getting pain, more pain when he takes breath in. So such patients, they may be complaining of these type of symptoms, dyspnea on exertion. So when I take breath in, so when I when I climb upstairs, or when I am walking, I'll be getting this symptom. So patients may not be knowing whether it is pleurisy, pleural environment, or something like that. So that will be these pleural diseases have also to be considered in the differential diagnosis. Okay. And then diseases of rib cage, as I said earlier, this musculoskeletal problem. So when a patient having this diseases of rib cage, so he will be having these type of symptoms. Maybe the presenting symptom may be this dyspnea on exertion. So those things have to be considered in the differential diagnosis. And we have some more points to differentiate post-COVID dyspnea that will come to further slides. So that we'll be discussing later. So, and then comes the cardiovascular diseases. So cardiovascular diseases presenting with the exertional dyspnea. So here our topic is exertional dyspnea. So cardiovascular diseases presenting with exertional dyspnea. So, so as you all know, when a patient is having cardiac failure, especially left heart failure, the main symptom, the presenting symptom will be dyspnea on exertion. In that we have this orthopnea as well as paroxysmal nocturnal dyspnea. So you may be knowing those things when I'm explaining those things. So today, and now also we are running out of time, so I'm not going to explain those things in detail. If I do explain, I will. Okay. So cardiovascular diseases, left heart failure, usually presenting with the dyspnea on exertion.
Dr. Lakshmi. Hello.
Okay, sir.
Dr. Lakshmi, today we have an important steering committee meeting after the session. So okay, we have to end in time. So please adjust your presentation
okay,
so
sir,
that
okay,
we will be ending in time along with the question and answer session.
Okay,
so,
sir.
Yeah, yeah.
Time.
I think now it is getting almost 9:30. I think.
Okay, sir. Okay.
Yeah.
Okay, but here, so for the diagnostic part, so we need a history and clinical examination for the proper diagnosis. In that we have, so first of all, we have to check the vitals, including blood pressure, pulse rate, temperature, and oxygen saturation. And we have a simple test to identify whether the patient is having dyspnea, or patient is having hypoxia or not. That is 6-minute walk test. I'm not going to explain those things in detail. And it is not necessary that patient should have a COVID positive test, that we can take it from the history. And antibody to COVID-19 test, that is it's not being done in many of the labs. And then comes the diagnostic investigations in COVID-19 patients. So as in all cases, we should have a routine examination blood. And so as in our case, so start with simple investigation, routine examination blood, then complete blood count, and we can have an NLR, neutrophil lymphocytic ratio. That's one thing we have to do in patients with the COVID-19, post-COVID inflammation or persistent symptoms. And we should have markers of inflammation like a C-reactive protein as well as ferritin, interleukin-6 and procalcitonin, and all these are markers of inflammation. And we can have markers of coagulopathy also as D-dimer. Then we can have cardiac biomarkers like troponin, then creatinine kinase, LDH, and natriuretic peptide, or ANF, atrial natriuretic factor. So those things are to be suggested in patients with the suspected post-COVID inflammation, persistent inflammation. And we can have a chest X-ray. It's a very simple investigation we can have in many of the patients and is available many of the hospitals. And then we can have a pulmonary function test, and that's also available many of the hospitals. Then we can have an ECG. It's also a simple investigation, and echo test. We can have an echo test to know whether the patient is having this cardiomyopathy or any chamber enlargement, something like that. And finally, we can have an HRCT. So in pulmonary parenchymal diseases, it is HRCT instead of our usual CECT, because diffuse pulmonary parenchymal damages should be investigated with this type of higher resolution CT. It is different from CT, and I'm not going to explain those things. So, and do not forget comorbidities. So many of the patients are having comorbidities. So we can have an RBS, lipid profile, thyroid function, renal function, and liver function test, as well as serum electrolytes. So we can have those things in our patients. So do not forget comorbidities in patients. And the chest X-ray as well as CT are the two imaging procedures that we can have in our hospital setup. So I'm not going to explain all those things because it takes time, and this is the typical radiological appearance. We will be having a ground glass opacity as well as consolidation and a crazy paving pattern and reverse halo sign. And these things are the typical presentation of patients with the post-COVID inflammation. And what's the ground glass opacity and how it differs from this consolidation. So I'm not going to explain those things. And this is ground glass opacity. And the peculiarity of ground glass opacity is we can see the this bronchovascular markings through this opacity. That's the peculiarity of ground glass opacity, and is different from consolidation, where we will not get this vascular marking, and we will get only this bronchial markings in consolidation. That's the difference of ground glass opacity and consolidation. And here also we can see a ground glass opacity here in this region, and here we can see an area of consolidation that is more opaque than the previous slide. And here it is CT picture showing ground glass opacity. So you can see some opacity here, and for comparison, one CT is shown here. That's a normal CT, and here you can see the opacity. Then again, one more CT picture showing the opacity or ground glass opacity with some crazy paving, and we have one more picture showing the typical crazy paving pattern of this post-COVID inflammation. Again, the reverse halo sign, as I said in the previous slide, this is reverse halo sign, an area of consolidation, and within that you can see an area of ground glass opacity. So ground glass opacity is surrounded by area of consolidation, and here we have a CT showing fibrotic damage. So about management, so since it is a multi-system disease, clinical management requires a whole patient perspective. So patient should be considered as a whole because it's affecting the whole system. It's a multi-system disease. So we are here. We can classify the patients into two groups: those who are having serious sequelae and those who are having non-specific clinical picture like a fatigue and breathlessness. Again, and then on whom to be referred and whom to be treated. So since this post-COVID dyspnea is a condition which has to be taken seriously because complications can occur in many of the patients. So we have to identify those patients. So in that case, whom to be referred and whom to be treated. And patients who need referral include with suspected so patients with the suspected thromboembolic events and suspected myocardial infarction or myocarditis or new heart failure. So those things have to be referred for other centers having facilities to manage such cases, and all cases with worsening breathlessness in spite of symptomatic treatment. So those cases also should be referred when their oxygen saturation comes below 94%. Okay, about management, general management. So reassurance, healthy diet, and this may be knowing for everyone. Everybody may be knowing about these things. Reassurance, healthy diet. So after having a viral infection, a debilitating infection, patient should be given with the this balanced diet. In that protein should be high because proteins are essential for the normal building up process of our body. So a balanced diet with the protein, fat, carbohydrate with the vitamins and minerals should be given in all patients. And when patients with pulmonary congestion, we can have this steam inhalation and control the regular exercises for helping for recovering from these symptoms. And pulmonary rehabilitation procedures are also there for as a management procedure. Then breathing exercises that also should be considered for the management part again. So breathing exercises should include slow inhalation as well as exhalation, but inhalation should be very slow process. And also you have to we can have this diaphragmatic breathing exercise. So breathing exercise which helps to improve the diaphragmatic function, that also should be considered in patients with the COVID-19 dyspnea. And here patients can have this pursed lip breathing for the better control of respiration, and this is respiratory exercises. You may be knowing about this thing. And effective homeopathic intervention can be made in those cases without structural pathology, and cases which do not require immediate medical attention, we can have homeopathic intervention. And since it is a multi-system disease, you can have a constitutional medicine to cover the constitution. But so along with this individualistic approach, you can have organ medicine having affection on that particular system. And if it is a pulmonary parenchymal damage causing dyspnea, you can have those medicines having action on this pulmonary parenchyma or respiratory system to cover the dyspnea. So you can have those medicines also. And in my experience, I use these medicines frequently in the prescription. And calcareous, that is the one medicine which comes frequently in my prescription. So calcareous having dyspnea with feeble heart and slightest emotion causing palpitation, especially when they are having obesity or morbid obesity, you can have this calcareous. But when a patient is presenting with this dyspnea of onset, dyspnea on exertion, you can have this medicine. So when you are not able to prescribe a constitutional medicine, when you are not able to find out a similimum in your OPD setup. So next comes coca. So coca is also a very good medicine when the patient says that he is not able to climb upstairs or is getting dyspnea when rapidly walking. So those are the symptoms of coca. So you can have coca in patients with these type of symptoms, when patient complaining of palpitation, dyspnea, anxiety, and sleeplessness. And again comes antimars, as you all know, ammonium carb, again one more medicine. Lacus is another medicine having this type of suffocation, and carbo vegetabilis again. As you all know, this carbo vegetabilis comes after a severe acute illness. So weakness after a debilitating acute illness, we can have carbo vegetabilis. So here also you can consider carbo vegetabilis in post-COVID patients. And also, when some patients are presenting with some functional dyspepsia and having these chest symptoms, you can consider carbo vegetabilis as well as Kylicarb, the two medicines having dyspeptic symptoms along with this chest complaint. So you can have these two medicines also. Antimonium tartaricum is rarely because antimonium tartaricum is having this cough and expectoration, and at home, one symptom is there that can be considered the impending paralysis of lungs. So that covers the post-COVID symptoms. So we can have all these medicines in post-COVID patients, but I recommend this constitutional medicine or a similar. That would be the better one if you get a constitutional medicine in patients, because this is a multi-system disease and it is affecting many systems of our body. And all patients are not getting post-COVID symptom, but some are getting constitutional, getting this post-COVID symptom. So you have to find out that particular constitution and have to be corrected. So with this, I conclude my presentation. I think I should learn more from the participants, because I know all of you are much experienced, well experienced practitioners. So you can share your information so that so if it is so well and good, so that I can share those information to our students also. Okay, thank you.